We're going to follow folks, and not like in a creepy way, but like in an appropriate, like, do you still want to participate way? We'll follow folks for 6 months, assessing their mental health, their overall health and well-being. We check in with them every month. We give them gift cards. We pay them for their time, right? Each time we talk with them. At the end of the 6 months, we do like full interview, and we're going to link it the outcomes to data from the ED and also from HMIS. So we're going to have strong data on the health, the outcomes of homelessness diversion at the end of the study, which we're excited about. It'll be the first one.
Well, I'm very excited to review the results as well. Can you talk through, is there anything that you've done in this project that has stood out to you as being surprising, or something you learned that you didn't think was true?
Yeah, I mean, I think some of the things that surprised me, and I don't know whether I didn't think it was going to be true, and some of these things are things that we suspect, right? But having them confirmed and hearing about them, and this has just been conversations with some of our case managers and staff. First of all, the demographics of the population were really different than what we anticipated. We thought that the folks that we were going to engage with would look more like individuals who are actively experiencing homelessness. When in fact, when you look at the breakdown, it is primarily, it's over 50% Spanish, only Spanish speaking. Mm-hmm. So we quickly realized all of our staff needed to be fluent in Spanish. There are a lot of women, a lot of families, and Hispanic identified in the Spanish speaking. So the demographics look really different than what we had anticipated, which means that some of the solutions that you're talking about also look a little different.
So are there any diversion kind of techniques that y'all talked about kind of in this work group that you were able to carry forward in the project that were really successful, or is there anything you want to highlight about the diversion services?
Yeah, I mean, I guess, again, we always talk about like, we need a success story each week. And so they share them. And sometimes it's hard, sometimes they're intervention and sometimes they're not. I think the one thing that I would want to highlight is, because the topic of this week is focused on the relationship between housing and healthcare, are stories that really highlight the intersections between housing and healthcare. And that's the number of people who went to the ED because they were had an accident at work, right? Maybe they were in construction, gig work, broke their leg, somebody broke their spine, right? And so go to the ED. And when we call them, they weren't concerned about their housing, but now they are, right? Because now they're concerned about being able to work, right? Living paycheck to paycheck. All of a sudden, your leg is broken. You no longer have a source of income. And so I think, we try to prime our team so that they know our rights, and how to like talk about and where to kind of get income to help support that interim period. But I think that example is a good one because it highlights that relationship between healthcare and housing. And then, of course, there's other stories about people who have, bills related to their healthcare and therefore are concerned about losing their housing.
I picked up on a thread that this is the first study, I think, of its kind, right? And so can you talk a little bit about just research in general and what that landscape looks like and why there's so little research currently on this?
Yeah, thank you. So, I think overall, there's certainly over the last decade or so, research on housing, homeless solutions have increased, but it's not where we need it to be, right? I think research is important. I mean, you all started this in such a great way. You're going to be like the data nerds, and which is very exciting for me to, to hear that that's where you're going and where you want to be. But, I think oftentimes we develop solutions, we deliver what we believe to be solutions, but there isn't always data for us to know that those solutions are effective or who they're effective for, right? And with a limited pot of money, and we always have less money than we want, right? And that's, or than we need, not even want, than we need, right? We need to figure out what works best and what works best for whom. So I would say that research is incredibly important. At the same time, I think it's limited for a few reasons. One is research is, particularly around homelessness, can be hard to fund because the project I just talked about was funded by NIH. Well, NIH will only fund something if it's focused on health, right? And so oftentimes funding agencies are only going to fund something that's focused on their specific outcome of interest, where I think a lot of the most exciting solutions are right now multi-sectoral approaches, right? But the funding solutions are not always kind of aligned with that. And so it can be challenging to find funding that's aligned with and wanting to support exploring and understanding solutions related to homelessness with housing as the outcome. I would also say there's a deeper reason. And I think that there's maybe historically there's some apprehension around research within the community for what I would say are very good reasons. I don't think researchers are always careful and cautious in terms of where those research questions come from, right? So it's a lot of like researchers coming up with a question and then pushing it onto the community, and then y'all are, what is this? Why are we asking folks to do this thing, right? And a lot of times it is asking folks to do something, and it's adding burden to your organization. And what do you get from that? I don't know. Your data's taken, right? And when we say your data taken, what does that mean? That means your stories, your expertise, right? Those get taken, researchers have them, and then researchers oftentimes benefit. And those results don't always get translated back into the community, right? So then what does the community want to do? They're not really interested in continuing to engage in research. And so, I think researchers need to do better, really listen to the community, make sure that those questions are coming from the community and that those results are ones that are actually going to benefit them in the long term. And at the same time, we need funding. We need funding that can support the academic side and the researchers, and can support the community as well.
Understood. Yeah, it's clear that no, you're good. And we are short on time. So I just want to get one more question in. I can talk to you about that all day, but can you tell us about Grassroots Health and your partnership with HHH?
Yeah, thank you. So I'll be quick this time, I promise. Okay, so Grassroots Health, so health is really exciting to me because we are exploring the relationship from healthcare to housing. Grassroots Health is kind of the flip of that, and we are looking at the relationship and providing services within housing, navigating folks into healthcare. And so it's primarily focused on hepatitis B and hepatitis C. The project's been going on for about 5 years. It's a partnership with HHH. Carly's will talk about it a little later. We started in permanent supportive housing. We're now moved over to transitional housing as well. We go on site. We provide education. We get folks tested on site. We come back, we knock on their door, hand them a letter with the results. We don't just call. We vaccinate them if they want to be vaccinated in that moment, right? We have somebody who's there, takes that moment, vaccinates them right on site. If they have hepatitis B or hepatitis C, we navigate them into care, including HHH. I will just quickly say, I talk more about hepatitis and why hepatitis is more of like a proof of concept, trying to show how important it is to bring healthcare literally to people's door, and eliminating all the barriers we can to them being able to engage in care. So kind of both sides of the spectrum, different projects, but similar work in some ways.
Incredible. Well, we're looking forward to hearing a little bit more about that when we come back up. But I'm going to bring Carly up now. Thank you. A quick round of applause for Dr. Schick. Thank you so much.
It's
fine. All right, so next up is Carly Brown. She is the Chief Executive Officer of Healthcare for the Homeless, also known as HHH. It's a federally qualified health center and nonprofit organization in Houston, Texas, that serves more than 6,000 individuals affected by housing instability each year. HHH operates a model of highly integrated medical, behavioral health, and stabilizing support services as a critical partner in Houston's collaborative response system to end homelessness. Ms. Brown has 2 decades of experience working in healthcare, spanning community-based research, program development, healthcare options, fundraising, and executive leadership. She holds a master's in public health from the University of Texas Health Science Center at Houston, a master's in healthcare administration from Texas Women's University, and a certificates in nonprofit leadership from Rice University. So without further ado, welcome. Quick round of applause for Carly. Thank you so much. Thanks for joining us. I'm going to open up the same way. Can you just tell us a little bit about yourself and a little bit about HHH?
Sure. My name is Carly. I'm the Chief Executive Officer at HHH. I've been in the public health space since I went straight from college into graduate school at the UT Health School of Public Health, which has changed its name since I went there. And so really, as Vanessa alluded to, I started caring about the issue of homelessness really from a public health lens, because that's what I was in school studying for. And early in my work, I was involved with more HIV and AIDS-related services, and got involved in a research study that looked at the intersection between HIV services and housing. And when that grant ended, I got a call from a recruiter. I was looking for a research associate at HHH, and that was 17.5 years ago. And so that's how I got into the homeless space. All of my questions are really about HHH. So
I think I'd like to understand where HHH sits in the homeless response system. What is its role?
Sure. So since we're talking about things from a little bit of a historical context this evening, I want to talk a little bit about what a federally qualified health center is. I know there's probably a broad scope of knowledge in this room, but FQHCs, or federally qualified health centers, means that you are part of the Community Health Center program, which is a federal program under the Bureau of Primary Health Care. This was a program that was started in the 60s under the Johnson administration as part of the war on poverty. And so FQHCs and community health centers play an important role in many systems. This includes serving patients who have very low incomes, people who are living in very rural areas, migrant farm workers, as well as people who are experiencing homelessness. So HHH's specific role, obviously, is serving people who are experiencing homelessness as part of this National Community Health Center program.
So why is there a need for a separate intervention in healthcare for the homeless population?
Good question. And also, I'm going to piggyback a little bit on what Vanessa was saying about literally bringing healthcare to people's doors. Mm-hmm. So we really know that one of the #1 reasons that people delay health services or don't engage in health services is because of stigma in terms of judgment. Mm-hmm. And healthcare is really a setting where you have to feel understood. And our job as healthcare providers is to create environments where people feel understood and accepted. And so our specific focus on serving people who have experiences with homelessness, because we only service people, we only provide services for people with homeless experiences, we're really able to tailor our model to meet the intersection between housing and other social determinants of health or non-medical drivers of health, and how that plays out in different healthcare settings. So, for example, when I go to my primary care doctor, there's not a psychiatrist sitting in the next room. In our clinics, we have psychiatry that's built in. We have community health workers that are literally in our clinics and in all of our programs. Our community health workers have experiences of homelessness themselves. And so they're very important in kind of the fancy term for it is cultural competency, in a way that we provide care in a cultural competent way. So you have a community health worker who has literally walked in your shoes, who is helping you navigate services. That's a hugely important part of our model of care. We have case management in our clinics and in our care teams, mental health providers, substance use treatment, literally in the clinic. So those things aren't built into the primary care clinic that I go to, but those things are built into the primary care clinics that we run. And then additionally, we go to where people are. So if people are living unsheltered, we have a street medicine program that literally goes into encampments and under bridges and meets people where they are. We're within permanent supportive housing, so we have care teams that knock on people's doors in supportive housing and connect them to care in that way. So it's really about both physically and kind of metaphorically meeting people where they are. And our services are entirely built around doing that for people who are experiencing this intersection between housing instability and healthcare needs and health instability.
Can you talk to us a little bit and just edify us on what a community health worker is?
Sure. So a community health worker is a certification that you can get through the state of Texas. And it's really based on this peer support model. And so you go through the certification to become a community health worker. And really it's this idea of not going into communities with this top-down approach, but coming from within communities to serve that community. And so when you employ community health workers, they are part of the community that you are serving, which is enormously important for the success of any program.
Absolutely. Yeah. Thank you so much. So we asked you here tonight to talk a little bit about Medicaid. Strap in, folks. We wanted to talk about Medicaid expansion specifically. So can you explain what Medicaid expansion just is? And what's the situation here in Texas?
So we don't have Medicaid expansion here in Texas. I think maybe everyone knows that. So under the Affordable Care Act, which was under the Obama administration, part of that was what's called Medicaid expansion. And basically the federal government said that we will foot the bill for almost the entire cost. Well, let me back up a little bit. Let me give a little historical context on Medicaid itself. So Medicare is for people over 65 is a federal program. So that means that if you're over the age of 65 and you can receive Medicare, you get basically the same coverage whether you live in Texas or Atlanta, well, Sydney, but wherever you live in the country, you receive basically the same access to Medicare. Medicaid, on the other hand, is each one of those programs are run by the state. And so your access to Medicaid is different depending on where you live in the country, which is different than Medicare. So that's an important differentiation of those are state-run programs. So that means that the states have the option whether or not to basically take the federal government up on their offer to subsidize the cost of expanding Medicaid to more people. And the way that it's structured is that it expands it to more people by eliminating all of the other criteria other than income. And so I think the way it's written is like, if you live at 132% of the poverty level or effectively 138% of the poverty level, then you would just qualify for Medicaid in your state. And there were no other restrictions on it. And so it kind of unified the Medicaid program for states that expanded Medicaid. Texas did not take the federal government up on its offer to put most of the bill to expand care. And in fact, we remain one of the most restricted states in our eligibility criteria. So really we're restricted to not only the income level, but also largely you have to be a pregnant or postpartum woman under the age of 17 or have a well-documented disability in order to qualify for Medicaid, which means that it excludes many, many, many people who would be included in 40 states that expanded Medicaid. There's only 10 that did not.
I think we could probably gather, but can you just tell us what that looks like in terms of impacts on the ground and not being able to provide those services for population we talked about tonight?
Yes. Well, so there's two implications, right? There's the financial implication because, for example, at Healthcare for the Homeless Houston, everybody that we serve was far below the poverty line, but our revenue from Medicaid every year is about 1%. So it is not a game changer in our revenue model at all, which means that we have to find other ways to pay for the care that we provide. And the care that we provide is very, very comprehensive. Psychiatry is not an inexpensive thing to provide. The type of substance use services and hepatitis C treatment and medication assisted treatment for like opioid use disorders. These are not inexpensive things to treat. And so if we don't pay for that with Medicaid dollars, we have to pay for that through other funding sources, which makes it very complicated. There's a lot of compliance if we use public funding, things like that. Our chief development officer is here tonight, Catherine. She has a very big job trying to keep our doors open on a funding basis. So there's the funding implication, but then there's also the access to care implication. And so for our patients who don't have insurance, which is the vast majority of them, if they need to go see a specialist, they have very, very limited options where we can send them.
Mm-hmm.
So Harris Health is a very close partner of ours and is the public health system here, and who we largely rely on for any kind of specialty services, cardiology, oncology, really any kind of specialty services. And they have more need than they can meet as well. And so there's extraordinarily long wait times, depending on the specialty. And they do a great job. This is not a slight at Harris Health, but they are a public health system that doesn't have enough funding to serve the number of people that need their services. So it creates additional barriers for that. And then also you have to get, it's not called a gold card anymore, but it's basically the financial assistance program of Harris Health. And so there's also just barriers to getting people engaged in the Harris Health system. It's an enormous system of care. So folks who are struggling to even get to our doors, also an enormous amount of barriers to get through the doors of Harris Health. So long answer longer. There's financial implications, but then there's real access to care issues. And when you put that many barriers to access to care, it has enormous implications on overall health outcomes. And those enormous implications on overall health outcomes have enormous implications on overall housing stability. Mm-hmm. And so when you sort of marry those two, it becomes a cycle between emergency rooms and homelessness and housing instability in emergency rooms and homelessness, which is why Dr. Schick's program probably picked the emergency room as one of the intervention points, because we see that a very common cycle between those things.
Well, I'm glad we invited you both, because it's clear that there's a need for multi-sector collaboration.
There is. We are one piece of the puzzle. I mean, we work very closely, like I mentioned, with Harris Health, but we work very closely with our social services partners, with our housing partners, New Hope Housing, Timonos, Harmony House. I mean, we all are in this together and have a very specific role that we all play as a piece of that puzzle.
So I've been in this role for about 2 months now, and I've heard the term 115 get thrown around a lot. 1115. Yes. Can't even get it right. With Medicaid. So can you just explain that to me? What that is?
Yes. And you're welcome. I didn't come up with these questions. So 1115 Medicaid waivers were sort of the answer to states that didn't expand Medicaid and thought they could do this in much more innovative ways, had access to essentially block grants that are called 1115 Medicaid waivers. And they fund what are called demonstration projects or pilot projects, at least initially. And kind of where this fits into the homeless response system is that initially, I think back in 2014, under Annise Parker, when she was mayor, she really made addressing homelessness a key focus of her administration for her own personal stories, which she has shared widely. And really the timing of the 1115 waivers was important in her administration because she used that to enormously expand permanent supportive housing programs. And that was very instrumental in shifting Houston overall as a model from what was called housing ready, which meant you had to be kind of stable enough and sober enough, and you had access to enough healthcare and enough services that you were like ready to go into housing, which is not a model that works very well, as you can imagine. It funds a lot of shelter services and at the expense really of housing services, and so it's just kind of the balance that we choose. So really the expansion of permanent supportive housing under this 1115 money that the city got influxed a lot of resources into moving us to housing first, which is the model that we use today. And it is based really on permanent supportive housing, some other models as well, rapid housing and things like that. But largely this permanent supportive housing model is our housing first. And so we used $1115 to build out those programs and to really model on-site healthcare services paired with case management, so that once people were in housing, and these are folks who had experienced chronic homelessness, so had a lot of really profound health and social needs and housing needs that intersected, to build up those programs where we were providing on-site care in permanent supportive housing, so that once people got housed, we could help them maintain enough stability to remain in housing as a permanent solution to homelessness rather than kind of the cyclical idea of homelessness.
And have we been able to carry those demonstrations forward? I know the pilot project.
Not under 1115 money. So the 1115 money that initially funded those programs in Texas and Houston now, this is a very complicated system, but has basically gone now into the hospital systems, into the nonprofit hospital systems, not necessarily the public, not Harris Health, but essentially they provide increased reimbursement for state Medicaid dollars to hospitals. And this is not like very transparently, the way that hospitals use 1115 money is not my area of expertise, and it's a little bit different depending on which hospital you're talking about and how they're allocating their $1115, but it is almost entirely in the hospital systems.
Understood. And the last question about Medicaid, I promise. Can you just tell us a little bit about what other states that do have expansion are doing and what we might look to?
Sure.
Have
Yeah.
expansion here?
It's interesting, actually, every year. So there's a National Healthcare for the Homeless Council. So as I talked about earlier, that Healthcare for the Homeless Houston is not the only homeless specific FQHC in the country. We are the only FQHC homeless specific in Houston. But it's a national movement of health centers that are really involved. And in fact, we have one of our VIPs at the National Healthcare for the Homeless Council, Charlotte. And it's interesting because we have there's an annual conference that we go to each year, a policy symposium. And the stark difference between programs who are in Medicaid expansion states and non-expansion states is almost like you need two conferences now. I mean, we just barely speak the same language because there's such a difference in resources. Mm-hmm. And there's some really cool things that are happening, really innovative things that are happening in states that have expanded Medicaid. Right now, California, for example, is using a lot of their Medicaid dollars to expand housing as a solution to their housing crisis. Another way that we've seen states use Medicaid expansion money is we've seen a lot more medical respite programs pop up across the country. And those are largely supported by Medicaid dollars. And what medical respite programs are, in a very brief nutshell, is that when people get out of the hospital, typically they need more care than they can give themselves or that they need if they're living unsheltered or in unstable housing. So they might have like IV antibiotics, or they might need wound care. They might just need somewhere to sleep while they're recuperating. And we know that not having that just creates really high rates of going back into the hospital and much longer length of stay once you're in the hospital. And so these medical respite programs are almost like a hospital step down, where you still have nursing or medical staff that are helping to provide care as a prevention for going back into the hospital. But they also offer an opportunity to then kind of provide these wraparound services that we see in permanent supportive housing, for example. So maybe somebody in that respite care program, you're providing wound care to them, but we can also introduce the idea of substance use treatment engagement or psychiatric stabilization or introduction to mental health services, and in ways that are more successful than kind of trying to trap people in different places. So it kind of provides this avenue of additional opportunity for care.
So what does that model of medical respite look like in Texas, given that we don't have that expansion?
There's none, well, there's a small one in Houston now that's run by Harris Health, and it's an open door admission. That's the only program in Houston that's that medical respite model. It's a small program. I would love if we could really look at expanding access to medical respite, because I think it would be a game changer for not only healthcare access, but also what that means in terms of perpetuated homelessness. And I think it's a fantastic intervention to really move people into stability and into housing. There's a program in Austin, but I think other than that, pretty limited.
Medical respite light here in Texas.
Medical respite light here in the non-expansion state of Texas.
Understood. I just want to give you an opportunity. Is there any other work that HHH is doing that you'd like to highlight before we bring Dr. Schick back on?
I don't think so. I talked a lot. I mean, I can, no.
Okay. Well, Dr. Schick, you want to come back up here and we'll take, so the way that the rest of the evening will go, I have some questions for both of you folks together, and then we'll open it up to the audience for questions. So let's get you on. Yep. Yeah. I'm just going to hand the microphone to you. This one,
We can share, or we'll just like. Actually, I'm in full circle. Dr. Schick was one of the people I worked with evaluating the initial 1115 permanent supportive housing programs. And so we worked closely doing evaluation on the 1115 housing programs, not a hospital.
Well, and when you asked why this work, I wasn't really focused on individuals experiences when I first moved to Houston. But I met Carly, I met Francis at HHH, and began to work with them, and actually was there one day a week for several years, kind of connecting and learning about the community. And so I really started this work with Carly and with HHH. So this is really a lovely.
It's incredible.
Yeah.
It's a small world. So I'm going to ask you the question of the we've heard that housing is healthcare. Does that ring true to you? And what does that mean to you?
I mean, I think housing is very beneficial in the provision of healthcare. And I think, you know, housing is one of the social determinants of health. It's one of the leading sort of indicators of health status is also your housing status. So they're really inextricably linked. My question really around this and what I've sort of posed rhetorically is, if housing is healthcare, then what the hell are we doing at HHH? I mean, we don't provide housing, we provide healthcare. We provide healthcare in housing, and it's an important part of that whole puzzle piece that fits together. But I don't know that housing in of itself is a treatment for diabetes or psychiatric conditions. It doesn't provide substance use treatment or trauma-informed models of care. And so I think they're equally as important, but I don't think that they're the same.
Yeah, we didn't talk about this beforehand, but I think we're pretty aligned here.
You might disagree.
Yeah, I mean, I think when people say housing is on there, I understand that, understand why it's important to say that. At the same time, I want to dig in and say, what do you mean when you say housing is healthcare, right? Because it's not a mess, right?
Yeah.
It's not that like it works unequivocally for everyone every time without the addition of healthcare. right? We know that healthcare and housing, as you said, they're inextricably linked to one another. We talked about connections between them earlier. But at the same time, we know that housing can lead to better health outcomes. It is most definitely what we would call a non-medical driver of health. Having housing is so important in terms of keeping people out of unsafe conditions, and also in terms of having a safe place for people to be able to connect into healthcare. Okay, so for so many reasons, it's related to health. But the data is, and let me keep this and throw me out of here. Okay, I guess. The data is a little inconsistent. Like if you look at the National Academy's report, it says we need more data to better understand the relationship between housing and health. And so we see sometimes there are direct positive relationships, and sometimes the story is a little more complicated. And so I guess what's interesting to me is sometimes when it's more complicated. In what ways is housing help, and who's it helping for, and is it just housing that people need, or is it housing plus employment? Is it housing plus health insurance? Like, in what ways does housing lead to these tremendous health outcomes that we're focused on? So I wouldn't say that statement is true or false. I'm going to say, I'm not saying anything else. All I'm saying is that sometimes I think that it's a little bit more complicated, and I think it's what's fun is digging in and understanding that complication and where we need to continue to learn and grow and understand that relationship.
Thank you for walking out the nuance, because I think that's where change actually happens, is when we sit in the nuance. So before we open it up to audience questions, I just want to ask is, what do you want folks in the audience, both in here and at home, to remember, to take away from this talk? Anything's important for y'all?
What does FQHC stand for?
Excellent.
Just kidding. But it's federally policy and health. We just did an all staff meeting, and we played Jeopardy, and Catherine and I made up a bunch of questions, and we did quiz staff on like what does FQHC stand for, and I was very proud of them that they almost got it. Almost. There was a federally qualified healthcare center. It was so close, but judges ruled in their favor. So
yeah, so remembering one thing, can I, if you ask?
Go for it.
Okay, sure. Folks, three things, if you could. The first is with Project Pulse. If you have a program, an intervention, anything at all that you think would be really helpful in diverting people from experiencing homelessness, please reach out to me. We would love to have you share that with the team, so that way we're getting those resources to people. I would be so grateful. Ask number two, I got to read. Ask number two, grassroots health. We are offering hepatitis B and C vaccination treatment, no cost. In fact, we give people gift cards. If you have a housing site where you are willing to have us reach out, we will be there. Daytime, nights, weekends, we're there. So that's my pitch. Please reach out to me. And then my third pitch is just a larger one. If you have a program that you're excited about and you feel like we would love to have some research on this, I'm happy to chat with you, think about what that might look like, if that's something that's interesting to you. So that's just like a broader. If you ever want to chat about research or opportunities, come chat with me. Would love to get to know you.
And how should folks connect with you?
There was a slide. You can email me at vanessa.schick@uth.tmc.edu. I will repeat, vanessa.schick@uth.tmc.edu. I would be so grateful to hear from any of you that are willing to connect with me.
Carly, what should people who are interested in reaching out to you, what do you want them to reach out to you about? How are you interested in connecting with folks?
Really, if you're interested in talking about anything, we'll talk with you. So whatever your interest is our interest. I mean, I love connecting with other people who are even just interested in this work or want to know how to get involved or have ideas around things or want to debate whether healthcare is housing or housing is healthcare or any of the above. We did bring some just really one-page pamphlets, and so there's a QR code, and I think our information is on there, and so please don't hesitate to reach out if you want to tour one of our clinics. We have 3 brick and mortar clinics, and then are across a lot of Houston. So if you want to come see what we do every day, if you want to see those like that, to a primary care doc, come on down to the clinic and show you around.
Amazing.
Yeah.
Well, thank you both. We're going to take some audience questions now.
Okay.
Let's see those
My name is Dr. Kristen Kennedy. He's recovering my father on. I think for me, information. When I walk over what we like, it's just like so we mentioned the home study, including them that helps us identify leaders of them and more individuals who are in the study. What services are being provided? Do they like help that? And in the beginning of the study, like many partners who were like, I not what data, but I'm sure they would all do that. And there were one way by not. But individual organizations like mine are now, we don't have to go that way. So for grassroots organization is trying to do right thing, how do we start?
I mean,
Just want to repeat the question.
oh, I think the question was, as a grassroots organization, if you don't have the resources or technology to collect data, then what are some ideas that I've captured that? So I'll let you take the majority of this, but I will say that I always say, like, well, what questions do you want to answer? And you don't usually need like super fancy tools to do that. I mean, you can do an enormous amount of things in Excel. And it's really about being information. You can, but what's the thing, like you can be data rich and information poor. I mean, what's the information that you're looking for? And it doesn't typically, unless you're going to do these like gigantic research studies, if you're a grassroots organization that just wants to answer some questions about how you're doing on a service level or things like that, I mean, you really can do a lot with tools like Excel and even more what we would call like qualitative data, where you look at like anecdotal data and you analyze that for themes, and that doesn't require like an expensive statistics package necessarily. Just someone interested in what you want to know and how or call Vanessa.
Yeah, that's good. I love that answer, including the animation.
And call Vanessa.
I think maybe two things. One is you don't need to take on the burden of doing all of that yourself, right? So I think that this is where those partnerships come into play. So I think you don't need to tell me, I would love it if you did. But reach out to other maybe university partners, right? Because there's a lot of folks who are really hungry to support the community and learn about what's happening, and who have some of those resources. And if they, maybe the faculty themselves can't support it, there's amazing students who we can connect you with, who can devote time and resources to do the information class, and also and will be supported by faculty in doing it. So I would reach out and connect you, not just UT Health University, since there's so much good.
I was about to volunteer Dr. Ben King as well. What's your email address, Ben?
But yeah, I think connect and we can hopefully connect you with resources. And then two is, and anybody from University of Texas, don't listen for a second. We have sometimes access to things like all tracks or red hat, some of those programs they get a university license for, right? So there's strategic ways for us to work with community and lend some of those resources. We're not making that purchase, and we're then able to collaborate. Thank you. And
Yes. Well, with that, we'll end tonight's discussion. I just want to thank you both so much for taking time and answering all of our questions. And we just really appreciate y'all coming out. So thank you so much. Let's give it up for them. Thanks, y'all. Of course, yeah. So mingle, and we'll be around. Thank you all. Have a good night.
Right on.